belly is what we all call it. We think the patient in room 4 has a hot belly. That's what we call it. Now, peritonitis, as you can tell by your handout, the patient can have all kinds of reasons why they have a peritonitis. The most common reasons, all GI is dirty, and anything wrong in the GI department is going to give you a dirty bowel. And the dirty bowel things that you can think of, pancreatitis. You have to think about perforations, all give you peritonitis. Anything that perforates is going to give you a peritonitis. Even a ruptured ectopic pregnancy will give you a peritonitis. So it's absolutely crazy. It's just dirty bowel syndrome. Now, this patient with this dirty bowel syndrome, if you look at it, our little rhyme about IV, NG, Foley, surgery, our little rhyme is pretty much on this page. So let's look at what we got. We got IV. You'll see it's in his right cephalic vein. If you follow the IV, what do you think the little piggyback is? Look at the picture. Antibiotics. What's next to it? So a maintenance bag, isotonic solutions, right? Isotonic is normal saline and LI. Okay, so we did our IV. He has an NG, doesn't he? Okay, the NG is for gastric decompression. In this case, we don't like it. What's going in his NG? Looking like blood, isn't it? Okay, you don't want no blood in the NG. If blood is an NG, call somebody yesterday. Okay, so we have this NG, and then IV NG. He's going to get a Foley, but he has a classic hallmark sign to show you. Look at his stomach. Look at what the illustrator did. It made a box. Y'all see it made a box in the stomach? Highlight board-like abdomen, abdominal distension, and rigidity, because you know you had to know that. Board-like abdomen, rigidity, distension. You had to know rebound tenderness. Rebound tenderness means you pressed on it and said, sweetheart, does this hurt? And they say, no. And then your hands go like this. Ow! That's rebound. That's Tristan Thompson. You took your hand off. You got a daggone, rebound. Okay? Now, that's really seen with appendicitis. Okay? Now, here's our deal. Watch this. The patient with this horrible situation, it will be all of a sudden. You have to know that. They're going to complain about severe pain all of a sudden. It's going to be in the epigastric area. As with all GI emergencies, they're going to be in a fetal position, all balled up. And they're going to have diminished bowel sounds. You're going to keep the head of the bed up. Now look at the left-hand side of your page. It says diminished bowel sounds. Do you see that? Highlight it. Left-hand side of your page. It even says shh, bowel sleeping. I don't know if you see that little box there. It says bowel sounds are diminished, decreased bowel sounds, and it says shh, bowels are sleeping. You've got the pain. You just write the epigastric next to that. Your patient is vomiting profusely, so they have dehydration. If they continue to the point of losing a lot of fluid and there's blood involved, the high BP that you see on your sheet, because they're in pain causes a high BP, the high will go to a low if they lose so much fluid. You knew that. Volume controls fluid. They're definitely tachycardic. They're definitely feverish, which is on the right-hand side near their mouth. They're feverish, and you can put this in there. All GI is dirty. So all GI is infected. Every single GI patient is infected with something. If you look at the risk factors in the bottom of the sheet, any abdominal surgery, ectopic pregnancy, I would highlight ulcer for you. Ruptured appendix, I would also highlight diverticulum. And let's give you some information on the diverticulum. I told you Saturday that the diverticulum involves your sigmoid colon, left lower quadrant. Due to the aging process, just getting older, you have pouches. Just getting older, you have pouches. Seeds and things can get stuck in the pouches. Seeds, everything. The patient had no fiber. They were dehydrated they were constipated their whole life. This patient might have bought over-the-counter constipation drugs. They were constipated their whole life. 30 years of this, 20 years of constipation. Now, when you get them, if there's a diverticulum that ruptured, it'll be, again, all of a sudden, but instead of epigastric, it'll be left lower quadrant pain. They'll be doing everything that the other one's doing. Throwing up, fever, chills, bleeding, and it's a medical emergency. Okay. If you look at the top of the NG, it says treatment, identify the cause, and antibiotics. Highlight the antibiotics. Remind yourself all GI is good. If you look at the bottom box where it says nursing care, highlight electrolytes and remind yourself all GI is dirty and all electrolytes are lost when you're vomiting. So we're going to write this again because it's just going to help you and you're going to be feeling better and better about it. IV, NG, Foley, surgery, electrolytes, antibiotics. Done. The next page probably has peritonitis on it as well. Turn to the next page. This page, I want you to put some GI bleed information. And I want you to, where it says nursing care, go ahead and put head of the bed up in semi-Fowlers. Head of the bed up in semi-Fowlers. And for this page, I want you to put some GI bleed stuff. Here we go. Number one, a GI bleed is a medical emergency. They're going to need an IV times 2. An IV times 2. Not just one, they're actually going to need 2. Number 2, this GI bleed patient, if they are bleeding from the top, they're either going to have hematemesis, which means throwing up blood. Hematemesis. So an upper GI bleed, hematemesis. And melena, which is tarry stools. They could have coffee ground emesis. This is all your upper GI bleed. It could be from a peptic ulcer. So any of the PUD patients could do this to you. It could be from a Mallory-Weiss tear. A Mallory-Weiss tear is going to be a tear in your esophagus. It could be from esophageal varices. Any one of those reasons could give this patient a GI bleed, an upper GI bleed. In this case, we say IV and G. Well, IV times 2. I want to be clear about that. IV times 2, 18 gauge. IV times 2. NG, which is NG and PO. So I have to be real clear on this one. NG and PO. EGD, which is, again, in your procedures package, you can look at it, glance at it later. And EGD includes 3 body parts. Esophageal, gastro, duodenoscopy. upper GI bleed, esophageal gastroduodenoscopy. So that's important that you know that. Okay, so IV times 2, NG, NPO, EGD, Foley, because you're going to have major surgery, you don't need the bladder in the way. And one of the things we may do with your NG is a PRN thing, and you have to know it, is a lavage. Ice water lavage. Lavage, L for leave-in ice water. L for lavage, L for leave-in ice water. Ice water, I should say, through the NG2 lavage. It's going to vasoconstrict. So we're going to vasoconstrict this patient because they're bleeding. So ice water lavage. The patient gets surgery, of course, to close the perforation that could have caused the peritonitis. So surgery is needed if the reason is a perforation. Surgery is very important if there's a perforation. Meds that we would use with this guy, medications that we would use with this guy includes vitamin K, vasopressin, natriotide, we talked about this yesterday, which is your octreotide and natriotide, but they use natriotide as a quote. That's an emergency medication to stop all the secretions in the GI system. So octreotide / natriotide, same drug. Blood transfusions, many units. IV fluid volume replacement. With this patient that has this GI bleed, I want you to remember NSAIDs could have caused it as well. And you guys know what NSAIDs are. Those are Motrin, Advil, Aleve, all that stuff. The risk of this patient is hypovolemic shock. That's the #1 complication from a GI bleed. Hypovolemic shock. Because of that, you're doing vital signs, pulse ox, and LOC every 5 to 15 minutes. Every 5 to 15 minutes. Because it's a GI bleed, your patient really needs a central line, but you're going to give them the 2 IVs until they can get it, because you don't put in central lines yourself. They're going to have a board-like rigid abdomen. They're going to be in that fetal position we keep saying. Quote me on this, your patient needs to stay in semi-Fowler's position. And then they need a PPI. PPI is a proton pump inhibitor, right? Proton pump inhibitors. If we have to, and the bleed is from an ulcer, we're going to do a selective vagotomy. A selective vagotomy, if this is due to ulcers, is literally cutting out a portion of the vagus nerve. Cutting out a portion of the vagus nerve. I want to be real clear that an upper GI bleed could be bright red hematemesis, coffee ground emesis, melena, which is going to be tarry stools, and that's because when the blood was up here in the stomach and the duodenum, some of that blood went through the entire digestive system and got digested. So it's melena, which is tarry stools, okay? Some of it came up as hematemesis. Some of it might have came up as coffee ground emesis, which meant partial digestion. But you could have either one, tarry stools or bright red vomiting. Lower GI bleed needs a colonoscopy. It's lower. colonoscopy, colon's your large intestine. The lower GI bleed could have this big $4 word. I love. Don't you write that flatten. Here we go. Hematochezia, that's the word I want. Oh, from a $4 word. Hematochezia is bright red rectal bleeding. Bright red rectal bleeding. Bright red rectal bleeding, hemorrhoids, polyps, cancer, any number of reasons why you have lower GI bleed. Okay. If the GI bleed that is lower is high in the large intestine, you have a positive fecal occult blood. So that whole guaiac, positive occult blood. If it's a little bit higher in the colon. So here's what you had on, well, we'll just say quoting. Get this, because you don't hear me keep saying it. Your right side of your large intestine is higher up. If this patient has a higher up bleed, it's going to be positive for occult blood. In other words, it's hidden bleeding because it's so high up. If it's in the lower part of the colon, which is the left side, and I need you to know left from right GI bleed. So left lower GI bleed is going to be the hematochezia, the bright red. It's closer to the outside. That's why I keep saying left side is colon, poop, okay? You just have to keep those straight. All right, done with that.